access to safe supply might not be as readily available?
I think we absolutely need on-demand treatment, high-quality evidence-based treatment using the full range of modalities, including injectable opioid agonist treatment, which really has not been expanded at all in our country.
Do you believe the federal government is doing enough in terms of rolling out a plan with a timeline and resources?
I'm not sure if the committee has heard this evidence, but we know in Alberta and BC that the majority of people who die from drug poisoning are dying after smoking drugs. And yet supervised consumption services across the country, very few of them actually allow people to smoke drugs within them. And so a pretty quick change that could happen is for the federal government to subsidize supervised consumption services to make the renovations required to be able to accommodate supervised inhalation.
This guy's garage. Like and subscribe.
No, I understand that current available treatment option is an area that you've been looking into, and you've been doing some research, and in that and a safer supply. Can you shed some light around how these available treatment options, along with a safer supply, will be able to help present an alternative to the situation that we are, the dilemma that we are facing with?
Yeah, so I think I echo everybody on the panel that it is critical we respond with a wide variety of different opioid agonist medications and options for people, and that we need to dramatically expand access to those medications as first-line treatment for opioid use disorder. But we also know that there is some patients for which those medications are either not an option or not something they've tried and has not been successful for them. And I don't think it's okay to just say, well, I'm sorry, that's all we've got for you. I think it is reasonable to prescribe people prescription opioid medications in an attempt to stabilize them and to support them and to reduce their extreme risk of overdose death from consuming fentanyl and other toxic street drugs. So I don't think that these are opposing things. I think we absolutely need on-demand treatment, high-quality evidence-based treatment using the full range of modalities, including injectable opioid agonist treatment, which really has not been expanded at all in our country. But that being said, there will be people that, for whatever reason, those medications are not an option or have not worked for them, and we can't abandon that population. We really need to support everybody we can to stay alive. It's just not acceptable to have this level of death in our country for something that is ultimately preventable. So
last question coming to you is, you also, in your opening remarks, you talked about the societal response that we need to present, and also talked about some of the wraparound services. You got about a minute. Can you clearly expand on that? I know you went into a number of action items. What would be the top 3 societal response that would be able to address the issue that we are facing? Thank you.
Okay, we need to treat this like an actual public health emergency. We need to invest at the scale to ensure that the effective treatments we have, like opioid agonist treatment, supervised consumption services, naloxone, that's actually meeting population need. I would say that there's a lack of investment in these interventions to the point where they're not scaled to meet the need in the population. Beyond that, I think we need to look at the factors that drive drug poisoning death, which are increasingly housing, poverty, and comorbid mental health conditions. For example, in my home province right now, about 40% of drug poisoning deaths, just under, are occurring in public places, which is implying that that's a lot of people who are unstably housed or homeless that are currently dying as a result of drugs, obviously, but also the fact that they're rendered so precarious in these situations of being unhoused and having no support. So I think primarily the federal government really needs to step up the level of investment in services across the country in partnership with provinces, because we have just not scaled our response anywhere where it needs to be to bring down and achieve sustained reductions in morbidity and mortality across the country.
Dr. Kahan, you talked about the importance of OAT therapies in addiction treatment. And I was just wondering if you could expand a little bit on Alberta's model when it comes to the virtual opioid dependency program, how that works and how you think that could possibly be spread across the country.
Yes, I think the Alberta model has been highly successful. I mean, they are starting thousands of people in the same day on opiate agonist treatment, and that includes people in remote communities, people who have attended emergency departments or hospitals. And this is the way to do it. Canada is such a dispersed, geographically distant communities. We need to get OAT to where people are, in their communities, in the hospital, in the emergency departments. And virtual care is an efficient way to do it. They have 24/7 services, I understand it. It's not just virtual care. They have connections to prescribers, nurse practitioners, and physicians, as well as to pharmacies. So I think it's a very good model to make sure that people in remote communities and people who have lack of transportation, people who are in hospitals and emergency departments have access to care.
Thank you for that. I know I did a tour recently of the Calgary Arrest Processing Center with the Calgary City Police, and they actually had the ability to offer people that were recently arrested the access into the VOPD program right from the Arrest Processing Center, and were telling me some of the successes they had, which is a really cool build out. What are the barriers to getting OAT in Ontario? I know just in anecdotal conversations that I've had, people talk about the issue with the actual payment of how expensive OAT therapies are. Is that an issue in Ontario?
Well, I'm from BC.
Oh, sorry.
Right.
Then BC.
We've expanded
Apologies.
access to OAT enormously over the past 10, 15 years. And that has been, getting more doctors on board, reducing the restrictions, the requirements for licensing to get doctors to be able to prescribe OAT, and more patients have accessed it. We hear of constraints to access still in rural regions. I think it's, a symptom of our constraints in primary care provision. We have a shortage in primary care, and I think this population is severely affected. Payment, much of the payment that goes into OAT goes into the pharmacies, right? Direct witness
Merci.
ingestion fees and
Finissez votre phrase, Dr.
dispensation
Nozick,
fees.
il reste plus de temps.
Okay.
Dr. Heischka, you talked about the need for the federal government to declare a national public health emergency, something that the NDP has also been calling for. And we saw the federal government recently, they just hosted a summit on auto theft. But they haven't done anything like that on this crisis. And you talked about you've lost more lives in Alberta due to the toxic drug crisis than you did to COVID. Yet we saw the spending and the effort from the federal government is less than 1% of what they've spent in terms of responding to the toxic drug crisis than they have COVID. Do you believe the federal government is doing enough in terms of rolling out a plan with a timeline and resources? And what do you believe is necessary to respond to this crisis in the short term?
Yeah, I don't want to get bogged down in debates over the specific legal mechanisms of declaring an emergency or not, but I think obviously we need to recognize this for what it is, a public health emergency, and we need to substantially increase federal spending. And I think we also need to not only do that, but look at currently 60%, almost 60% of federal spending for the Controlled Drug and Substances Strategy is going towards law enforcement efforts. And I think we need to be looking to see if that is getting us the best value for money in terms of improved population health outcomes. We are not resourcing enough provincially or federally, social programs, healthcare, and a whole host of other options that can potentially be more effective at supporting people to stay alive and achieve recovery and get well. Beyond that, I think in the short term, there's a lot of things the federal government could do immediately to try to bring down the death rate. First and foremost, please do not cut the existing funding to safer supply programs. We know from evidence from different treatment studies as well as emerging safer supply evidence that if you abruptly cut people off their prescription medications, they're at a much higher risk of death. So just sustaining that funding, continuing to innovate in that area to look for more effective solutions, including non-prescriber models of safer supply. We just had a study published on the Compassion Club in BC that showed very early but promising promising results in terms of reducing mortality. Beyond that, I think we could be looking to improve safer supply programs by working with pharmaceutical companies and regulators to identify medications that are going to more effectively meet people's needs, potentially reducing the risk for diversion. Beyond that, I think we really need to look at a national project around decriminalization. I can't think of a stronger form of stigma than criminalizing someone. And we talk a lot about needing to end stigma, but then we continue to criminalize people for their health conditions. In BC, there is a imperfect decriminalization pilot happening. I think we need to have a national conversation about what this would look like across the country. And we need to first and foremost and permanently say this is a health issue. We need to stop criminalizing people, and that needs to happen across the country. It's not fair that people who use drugs in BC are potentially not subject to criminal charges, but everywhere else they are. I would also like to see an overhaul of the SUAP program. I think the way that the investments are currently made is not as effective as it could be. And I think we need to be looking at ongoing operational funding for evidence-based services as part of a core suite of options for people across the country. And I think federal funding could play a huge role in ensuring equitable access to treatment across the provinces, equitable access to safer consumption services, and other really proven interventions. I also want to highlight too, and I'm not sure if the committee has heard this evidence, but we know in Alberta and BC that the majority of people who die from drug poisoning are dying after smoking drugs. And yet supervised consumption services across the country, very few of them actually allow people to smoke drugs within them. And so a pretty quick change that could happen is for the federal government to subsidize supervised consumption services to make the renovations required to be able to accommodate supervised inhalation. And I think that would have an ancillary benefit of bringing more of the public drug use that is a concern across the country due to a whole host of factors, including a lack of housing. But it would bring that public drug use inside. And certainly this is a big issue in Edmonton, where I'm from. Many people are smoking drugs outside of supervised consumption sites because they cannot smoke them inside. And if they go down and have an overdose, they know the staff will run outside to help them. That's not an effective way to respond to a crisis. And it's something that could be addressed pretty quickly in the short term. And I think it would save lives.
Let's dive into Alberta. Much has been made of the Alberta model oriented on recovery and treatment. However, recent data highlighted that overdose rates in Alberta are rising fast since it was put in place, much faster than in British Columbia. Maybe you can talk about why do you think that is? You got about 60 seconds to do that.
Sure. I think it's always a result of multiple factors when we're looking at trends in drug poisoning. Some things we're seeing in our province that are concerning. There's been a substantial reduction in the number of people using supervised consumption sites. It's about half of what it was before the pandemic. And I think it is because of the lack of incorporating inhalation, as well as a number of closures and relocations of the services that have disrupted connections to care for people who use drugs. We are also, like I mentioned, seeing a lot more deaths in public spaces. We need to be addressing homelessness and unstable housing. I think if people had safe places to live with proper services and wraparound care, they wouldn't be dying of drug overdose on our streets. Beyond that, we have relatively low rates of opioid agonist treatment coverage for a province of our size. Only about 14,000 Albertans in Q3 of 2023 were being dispensed opioid agonist medications. That just seems to be quite a low coverage rate. And so I think we need to also do more to expand access to opioid agonist treatments in our province. And of course, I don't know why Alberta hasn't moved to trial safer supply. It is potentially a very powerful tool, as Dr. Nozick spoke to reduce mortality amongst a subset of people who use substances. And we need to use every single tool we have to address this generational and staggering crisis.